Again, as we talked about, these HIV codes are mutually exclusive. In other words, you can't use Z21 if the patient is being treated for any HIV-related illnesses. So you only use the Z21 when the patient has tested for the virus, but doesn't have any other symptoms of the disease. Once their disease progresses to AIDS, they are always coded with the B20. Once they pass that threshold where they have one of the manifestations of AIDS, excuse me, you use the B20 code instead of the Z21. So it's not like patients can go backwards and forwards. Once they develop an HIV-related illness, the patient is always assigned B20 in every subsequent visit or admission. The testing is, again, a status code. So with testing, it gets a code of Z11.4. These are just testing encounters. So in other words, the patients are coming in, they have no signs or symptoms, but they're being screened for it. If they're engaging in high-risk behavior, additional codes such as the Z72.5 are coded. Finally, if somebody gets HIV counseling at an encounter, you would use the Z71.4. Let's take a look at some of these codes. And again, here is what we were talking about. The Z21 is the asymptomatic HIV infection. And note the excludes one note. In other words, this is mutually exclusive. You can have AIDS, the B20. It's not contact. It's not exposure. It's not HIV disease. And it's not inconclusive. And again, let's find that screening code right over here. This is the encounter code used for the HIV testing, the Z11.4. If the results of the testing are positive and the patient is asymptomatic, code Z71, asymptomatic HIV infection, is used. If the results are positive and the patient has an HIV-related illness such as Kaposi sarcoma, the B20 for the HIV disease should be assigned. Sometimes we have sequela or late effects of infectious disease. These fall in the code ranges of B90 through B94. In other words, you would use these codes to identify the original condition that caused a problem that the patient now has as a result of the infection. B90 through B94 are not used if the original condition is still present or if the condition is chronic. These codes are late effects. They're the sequela of the initial infection. Bacterial and viral infectious agents are coded in B95 through B97. So basically, these codes are used to talk about an infectious agent that's involved in a disease classified elsewhere. And as we talked about earlier, B95 through 95.8 includes all the strep, staphylococcus, or enterococcus. B96.0 through B96.89, other bacterial agents. And then B97 through B9789 are all the viral agents. With these infections agents that are causing a disease classified elsewhere, look for the main term in the alphabetic index of infection, and then look for the name of the bacteria or viral agent. And then you may want to go down to the subterm under the name of the bacterial or viral agent as a cause of disease classified elsewhere. So start with infection, name of the organism, and then look for as a cause of disease classified elsewhere. So we'll give you an example in the second set of bullet points: upper respiratory infection caused by adenovirus. So we have main term infection, respiratory, upper, viral. Then we would pick up infection, adenovirus as cause of disease classified elsewhere. Another important thing to pick up is the infection with drug-resistant microorganisms. The coding of bacterial infections that are resistant to current antimicrobial drugs. These fall all in the code category of Z16. This code category is used to code any infection that's documented as drug resistance. The main term in the alphabet would be resistance or resistant. The subterm would be organism, and then followed by the alphabetic list of drug classes. Methicillin-resistant Staphylococcus aureus conditions. So in some cases with this condition, you would use a combination code that identifies the infection is due to a methicillin-resistant Staphylococcus aureus. So we have an example here: sepsis due to MRSA, A41.02. And then we would use an additional code to identify the MRSA as the causative organism with a code for the site of infection. So we would have I33.0 acute or subacute infective endocarditis, and then the B95.62 methicillin-resistant Staphylococcus aureus infection as a cause of a disease classified elsewhere. When we're looking for the main terms of these methicillin-resistant Staphylococcus aureus conditions, start with infection. And since Staphylococcus is a bacteria, we look bacterial as cause of disease classified elsewhere: Staphylococcus aureus, methicillin-resistant, and then we would find a code of B95.62. If the coder does not follow the subterms as a cause of disease classified elsewhere, the coder will access code A49.02, methicillin-resistant Staphylococcus aureus, unspecified site. We don't use that code when we have a specified site, in other words, with a code that identifies the site. A49.02 is used when the site of infection is not specified. Let's take a look at codes A49.01 and B95.61. So let's take a look here. Code category, bacterial infection. Note the excludes one notes. The A49.01. as we talked about. And then B95.6. Note here, don't get these confused. B95.1, Streptococcus group B as cause of disease classified elsewhere. What's different over here with B95.61 is right here, methicillin resistant. So you need to read this carefully to be directed to the correct codes. Finally, we get into coronavirus. This continues to be an evolving area that seems to have new guidelines and suggestions all the time. Coronavirus, as we know, is caused by the SARS-CoV-2 virus. We only code confirmed cases. We only code these confirmed diagnoses as documented by a provider or documentation of a positive test. Either one will do. For confirmed diagnosis, it's going to be code U07.1, COVID-19. So what's confusing here is this is an exception to the hospital inpatient guideline. So in this case, the confirmation does not require documentation of a positive test for COVID-19. The provider's documentation that they have it is sufficient. So it's one or the other. If the provider documents suspected, possible, probable, or inconclusive COVID-19, however, we would not use code U07.1. Instead, we would use the signs and symptoms code. In terms of the sequencing of codes, when COVID-19 meets the definition of a principal diagnosis, in other words, it's the reason for admission after study. If that's the case, then the U07.1 COVID-19 would come first, followed by any other codes for any manifestations, except when another guideline requires that conditions are sequenced first, such as in OB, sepsis, or transplant complications. For COVID-19 infection that progresses to sepsis, the sepsis guidelines that we saw in 1.C.1.D would apply in regards to sepsis, severe sepsis, and septic shock. Then finally, with the OB, we would follow those guidelines as mentioned in 1.C.16.H, and likewise for the newborns. And with transplants, there's specific guidelines. For any acute respiratory manifestations of COVID-19, the COVID-19 would still be the principal diagnosis, and any respiratory manifestations such as pneumonia, what have you, would follow. So looking at this with pneumonia due to COVID-19, it would be the U07.1 COVID-19 followed by the J12.89. And note that J12.82, pneumonia due to coronavirus, this became effective last year. Acute bronchitis. For any patient that has acute bronchitis due to COVID-19, once again, we see the U07.1 come first, then followed by the J20.8. Acute bronchitis due to other specified organisms. When we have a lower respiratory infection, if COVID-19 is being documented, it would be the U07 followed by the J22. Any acute respiratory distress syndrome due to COVID-19, again, you guessed it, U07 U07.1, followed by the J80 for the acute respiratory distress syndrome. Finally, acute respiratory failure due to COVID-19, U07.1, followed by the J96.0 acute respiratory syndrome. When the reason for an encounter or admission is a non-respiratory manifestation, such as viral enteritis, and it's due to COVID-19, the COVID-19 would be the principal or the first listed code. Likewise, kind of similar to what we see with HIV, exposures are coded differently. For anybody who's asymptomatic with an actual or suspected exposure to COVID-19, it's code Z20.822. For a symptomatic individual with actual or even suspected exposure to COVID-19, and the infection's been ruled out or the test results are inconclusive or unknown, but they've had actual contact, it's Z20.82. In terms of screening for COVID-19 during the pandemic, since it's a worldwide proliferation of these infections, a screening code is generally not appropriate. Therefore, we don't assign code Z11.52 encounter for screening for COVID-19. For any other of these encounters, including preoperative testing, coded as exposure to COVID-19 as per the previous slide right here. So in other words, we're going to be using that Z20.82. And again, one thing, this is an evolving picture, so there'll be new guidelines that come out in terms of things with COVID-19. Stay tuned. Signs and symptoms without a definitive diagnosis. So sometimes we'll have patients that present with signs and symptoms associated with COVID-19, such as a fever, but we can't establish a definitive diagnosis. In that case, since we don't have a definitive diagnosis, it would be a sign and symptom code, such as acute cough, RO5.1, RO6.02 for shortness of breath, R50.9, fever. Right. So again, if it starts with an R, it's a sign or a symptom, but without a definitive diagnosis, this is a code we would use. However, if patients have signs and symptoms, but they have actual or suspected contact with or exposure to, then it would be, as we saw earlier, the Z20.822. And again, as we think about this, it's always mutually exclusive. You can't be asymptomatic and have a symptoms, right? It's one or the other. You can't have the disease and be asymptomatic. So as per the second bullet point, if you have an asymptomatic individual who tests positive, he's no longer asymptomatic. Therefore, we would code it with the U07.1 for the COVID-19. Once people have COVID-19 and they recover for it, it is a history of COVID-19. So the main term would be history, personal, COVID-19, Z86.16. Once patients recover from COVID-19 and they're seen up for an evaluation and looking to see if they test negative, the code would be Z09, encounter for follow-up exam after completed treatment for conditions other than malignant neoplasm, or Z86.16, personal history of other infectious and parasitic disease. So in other words, you'd use both the Z09 and the Z86.16. That's all I have for you. We'll see you online.